Again, the topic of this presentation is about ICP. We return back to some basic invasive monitoring system, and we are going to talk about indication and method. We will start shortly, looking again at the physiology very shortly, and we are going to answer the two questions: how to measure and which patient do benefit of a monitoring system. Talking about physiology, we have a system with roughly 3 components: blood, tissue, and CSF in equilibrium. And we started to know in the 60s that the relationship between pressure and volume have a not linear relationship, but there is this shape with a flexion point and increased tip of the pressure with an increase of the volume. Normally, we stay in the flat part of this curve, and every beat of the heart, the arrow moves a little bit around the equilibrium point. If we have a mass, as you compare the boxes here, the first mechanism we have is reduction of CSF that is displaced from the intracranial space and go to the spinal space. And this buffer of the system allow you to accept a certain amount of volume, means 10, 15 milliliters, not so a huge amount of volume, and without any big change in pressure. We love to be non-invasive and would like to understand if the intracranial pressure is high or not with indirect measures. CT scan could give you some suggestion, because this mechanism, if we see a patient, this is an old patient with a lot of CSF space, and he had a trauma, unfortunately, after a couple of hours, the CT scan could become like the lower part of this cartoon. And surely, this patient is using some compensatory mechanism, but nobody could say which is the pressure in the bottom part of the slide. If we have a further increase in volume, we have a steep increase in pressure. So why we care about that? Because pressure produces gradient inside the skull, and we don't want, for example, to have a compression of a brainstem. And if we have high intracranial pressure, maybe we can have some clinical sign. We will discuss tomorrow with Tarek. The pupil unreactive is a sign of high intracranial pressure, but nowadays it's better to avoid this situation treating ICP before. We have some gradient inside the skull. We don't discuss about that, but the position of the probe could be influenced by this gradient you can see in this slide. We learned in the past century that ICP is linked with a reduction of flow. This is a paper published in 1948. So we know that ICP has a side effect having a reduction of cerebral blood flow. But we recorded, for example, at the backside with a desaturation of the patient when there is a plateau wave. In this case, this is a couple of, these are minute, and these are the effect of the plateau waves on jugular saturation. That means that we have an impact on flow of this situation. So we need some information, basic information of the sum of the volumes in the intracranial space. We are talking about trauma. In trauma, volumes change very easily after the traumatic event, and we need to have some information on the state of the compensatory mechanism. So the question we have to solve is how to measure ICP and in which patient. Measure ICP is an old story. One of the first recordings has been done by an Italian, Mosso, 1881. He recorded in patient, in subject with skull defect, the ICP, and he was able to notice that activity did produce changes in pressure. And he hypothesized, 1881, that the change was due to a change of the flow. So we are talking about a very long history. This man is Lundberg, one of the pioneers of the recording, and he said in the 60s some criteria that Anthony Marmaro reported at the ICP in Hong Kong in 2005. And I think all the criteria needs also to be present today. The procedure should minimize trauma to the intracranial structure, so we need to use a small catheter. We have to contain the risk because there is a risk of infection. And at this stage, the leakage of the system was a problem. It's not an important problem today. But we need to record for long term, without discomfort of the patient, ICP. It is not a snapshot. We are talking about the 60s. He wanted to have a long-term recording, and during diagnostic and therapeutic procedures, also in the transport today, we need to have ICP. And the apparatus need to be very easy to use and foolproof. Transferring this criteria is a more defined criteria, the American National Standard of Medical Instrumentation. We need a system that works in a huge range of pressure, 0, 100 millimeters, with a accuracy very good, 2 millimeters of mercury plus or minus in the range of 0 to 20, and the same applies in a range for 100 millimeters. All the ICP you are going to buy from the producer do respect this standard criteria. This standard criteria needs to be applied also to ventricular system because you became the producer. You buy a transducer from a company, you buy a catheter from another company, you put together two devices, and you have to be sure that in your hands these criteria have been respected. We like to be kind with the patient, not invasive. We already heard about the optic nerve insert, diameter. But I think it's not a monitoring system, it's a snapshot. You cannot apply this technique for days to a patient without having difficulties in keeping the probe and evaluating the optic nerve shift changes. But if you ask the question, this monitoring system, this system is able to identify ICP higher than 20, the answer is probably yes, with a good sensitivity and specificity. And the ROC curve says that you are able to understand if the patient has or doesn't have an high intracranial pressure. And the cutoff point was higher than 20 or lower than 20. But we are using invasive system today because this kind system, not invasive system, are not routinely used. And we will discuss about ventricular intraparenchymal system and not about the other system we are no more using because they are not so reliable. It's very easy. Lundberg in the 60s have this water column. It was measuring ICP with the water column. We are connecting an external transducer to here, and we can have on our monitor the ICP tracing. But the important point is that we need to keep a fixed reference to the external meatus. So you can use a laser, you can use other things, but you need to have a very good nurses team for keeping the level of a transducer correctly maintained. And on the book, there is written that this is the gold standard of accuracy because allow you to have a direct access to the CSF. The recording, if the water column is respected, is very good, but the main problem in our unit is to keep the fixed reference point that could add some errors if the patient moves, if the bed moves during the nursing. It's easy to calibrate. We do it 3 times a day in a sterile way, and it requires a fluid-filled column. Talking about the American standard, if we move the pressure level of a transducer, we can produce changes in ICP. The trace is an ICP over the threshold, the other one is the same patient, only with a change of the transducer. And the same applies if we open the CSF drainage, because we are not able to record a pressure higher than the level we are withdrawing CSF. So you have to keep in consideration this point. And for the difficulty sometimes to put the catheter in the ventricles, in the more severe patient, the ventricles are very small, as we saw in the cartoon at the beginning. Some technology advance come from the intraparenchymal system that are fiber optic or solid transducer system. These are the 3 systems on the market. This could be placed everywhere, in the ventricle, in the parenchymal, and subdurally, but the main position of this kind of device is intraparenchymal, and they have minimal artifact. If you need to analyze, we are used to analyze 150 samples a second, for example, for having the pressure, the PVI, the index of autoregulation. We have a very good resolution with this kind of device. You have to consider that we have an higher cost, and in this stage we have to consider closely the cost, and for the fiber optic device we have also the fragility of the system. We tested, for example, for one of these systems in the lab for a week, the so-called drift. So means that the signal, electrical signal, goes away from the real signal. And the drift in the lab for all these systems is very small, and they are reliable. But when you apply this concept in the clinical field, as you can see, there is a huge difference between the two systems, but we have to keep in consideration 2 points: the gradients inside the skull and the fact that ventriculostomy is the gold standard. But you can drive a Ferrari, but if you are blind, you will not win Monza. So you need a good nurse for having your correct number here, and the same applies to the other device. This is a Codman and the Camino in this slide, and the differences are huge in this study. If you apply the same concept for the intraparenchymal catheter at the removal, we ask every time to a nurse to take a look at the number at the removal of the probe. If you look, this has been done in the northern part of Europe, 128 patients. The drift at the end of the life of the catheter is not so huge as expected in the previous paper. And the Bland and Altman plot, in this case, present after 10 days of use a small difference between the gold standard. Talking about the fiber optic, we have also the probability to have some break of the probe due to nursing, due to patient activity, or sometimes for unknown reasons. So we have some system. We have to consider in our unit the cost of the system, the surgeon that put the probe, and the concept I give to my colleague, young colleague, is that you need to have an information in some patient, and you probably would like to have it from a ventricular catheter because it costs less, but if the surgeon in my unit is not able to put the probe, I prefer to have an intraparenchymal device instead of not having the information. The question is which patient? And if we took, as in many other topics, the Cochrane review, we know that we don't have any randomized controlled trial that clarify the role of ICP in acute coma. But I think yesterday Nino presented 2 papers about the ICP that doesn't improve outcome, and sometimes there is some discussion about that. No monitor by itself will change outcome. I usually say a story. There is an old colleague of mine, a neurosurgeon, a university neurosurgeon, that say, I was able to monitor ICP in the 70s, and I asked him, how did you do it? I put a catheter, I went home, at the last day, I returned back to the hospital the day after, I look at the tracing and I see a lot of curves, B waves and so on, but you were not treating the patient. You are measuring a parameter, but you are not doing the same thing. We are doing now, because from the monitoring system information, we are trying to change our treatment. And we can say that ICP is a low-risk, high-value monitor today. And when you don't have any very good evidence, I think the logic, extrapolation of pathophysiological principle is the classical skill for a doctor. And we know that the time spent over a threshold, this is the traumatic coma data bank population. If you spend 100% of the time over the threshold that was statistical 20 millimeters of mercury, you have a very low probability to have a good outcome. If you don't spend any minute over the threshold, your probability at that time was 30%, now is higher. But if you put together many studies, as Miriam Trejari did, and she published this review, this meta-analysis on neurocritical care, if you have a normal ICP, your probability to have a good outcome is a certain amount, but if you have a rise ICP, that you are able to reduce, looking, for example, at good recovery, moderate disability, compared to severe disability of vegetative state, this probability goes up and you have a 4-time increase of having a bad outcomes. And if you are not able to control this phenomenon, the outcome is worse than the situation in which you are able to control. I know if the patient doesn't have high ICP, you have a good probability to have a good outcome related to the first, the damage, the initial damage. Many series compare historically, comparison with previous patient, and says that protocols did improve outcome. Historical comparisons are not so strong and will not stop here. But if you look, for example, at center that measure ICP in more than 50% of the cases compared to center that doesn't do it. But you look at it, the difference is not only the monitoring, but the treatment. The patient is seen by a neurosurgeon, they apply some therapy, they do more CT scan. Doing a good job probably is related to have a better outcome to the patient. It's not switching off or off the monitoring system, it's treating the patient, and we already discussed about this slide twice in the last 2 days, and don't stop here. And I think the question is a trade-off between risk and benefit in the single patient. Because if you have a patient with a risk of 0% having an high ICP, we have to weight the risk to have an hematoma, very small, but it's around 1%, and the risk to have an infection. That depends on your series. My advice is to control in all series in your patient what is the risk of infection. But if the risk of having ICP, high ICP is 0, this risk is too high for the patient. If the risk of having ICP, very high ICP is 50%, I think you can consider the risk of having this kind of complication in the single patient because there is a very high risk of ICP, and the benefit for the patient will be the important part of this trade-off. And we have only one monitor. You have 4 minutes and we will finish. The only paper dealing with this question was published in 1982 when Narayan was a resident at the Medical College of Virginia. He monitored 226 patients consecutively. And he saw that differences in the CT, a positive CT scan is related with a higher probability to have an ICP. More than half of them did have high ICP. This is the conclusion of the work, but the conclusion of the work has been applied in the 3 edition of the guidelines. And in the time, if you look at the three different editions, having the same evidence is being weighted a little bit different because there is no randomized control trial on this topic. We have some evidence. In this case, we have one paper that says if you have a positive CT scan and a patient in coma, the risk of having high ICP is about 50%. And in this condition, you have to evaluate in patient. You think you are able to save them because in the previous edition, this part wasn't present. And so you have to treat patients you can save. It's wise to put an ICP device in this population. And the criteria identified in the past has been reduced to a level 3 evidence. It did see in the first CT scan that some characteristic, blood pressure, very low blood pressure, bilateral or unilateral motor posturing, and age over 30 was associated to high ICP. But this evidence has been reducing value in the last few years. Other conditions like subarachnoid hemorrhage have an indication of having a monitoring system. So every time you have a risk of having an imbalance in the volume and the risk is high, it's better to consider to have an ICP. I will conclude say that we are doing it invasively because today we are not able to do it not invasively. We used to do it continuously, not having snapshot as in the past. We put a catheter supratentorally, and we would like to have an ICP waveform display, for example, for having a quality assurance that the traces, like for an arterial pressure, we take a look at waveform. We would like to take a look at the waveform also about ICP. We will discuss tomorrow that ICP goes inside a trend of multiple parameters and not only alone. And we need to consider the close link between therapy and the response to the therapy. Thank you very much for your attention. I think we have 15 seconds.